All right. Well, good afternoon, everyone. Welcome to the American Board of Urology Town Hall meeting. Today is December 3rd. Here is the outline for our time together over the next little while. I'm Dr. Stuart Wolf. I'm the president of the American Board of Urology, just making this brief introduction. Most of the time is going to be spent discussing our CUC, rolling out a new program. Dr. David Joseph, chair of that committee, will be leading that discussion. Then we'll have an oral examination update from Dr. Chris Gonzalez, an update on the newly renamed fellowship URPS, Urologic Reconstruction Pelvic Surgery, by Dr. Ann Gormley. And then I'll briefly review the ABMS grant programs. Okay, Dr. Joseph, take it away.
Thank you. I'm just going to get to my shared screen here. And we should be good. Everybody can see that? Okay. Well, thank you, Stuart. And I want to thank all of the diplomats that have participated in the continuing urologic certification pilot. And moving forward, I'm just going to call it for brevity CUC. And I'm going to answer one of the questions up front that's come in. Everything you're going to hear about the CUC pertains to our primary certificate. It doesn't pertain to our certificates of added qualification in pediatrics or in urogynecology. And the reason for that is they will be falling under a similar continuous urologic certification program, but each one poses its own specific challenges, and we really needed to clear the hurdle for our primary certificate first. So that's what we're going to be discussing now. And one of the questions that it's always come up is, why is there always changes with certification? Time-limited certification came into play in 1985. I was certified in 86. And since that time, I've seen 4 different evolutions of the recertification process: recertification, maintenance of certification, lifelong learning, and now continuous urologic certification. And the point here is there's always evolution, and this isn't going to be the last change that we see in our future. But why do we have changes to begin with? And the need for that relates to our needs for alignment. We have to be aligned with what our patients expect. We need to align with the requirements of the ABMS. We need to be able to remain contemporary regarding our learning techniques and what we can offer our diplomats. And we need to reduce the time of making a summative assessment on diplomat knowledge, judgment, skill, and professionalism. Waiting 10 years is really not adequate. Moving it to a continuous cycle of at least 5 years is what we need to do. But equally, and probably most important, we needed to make a change because of what we heard from all of the diplomats about reducing the burden of particularly what's occurred with the 10-year point-in-time secure exam. For some individuals, it wasn't difficult finding a testing center nearby, but for many of the diplomats, that was not easy, finding a location or time. And so by making these changes, we're really adhering again to contemporary learning and computer techniques. We've now completed the 3rd year of our pilot, and we've had almost 1,000 participating diplomats that have made way in this. And it's to their credit and their contributions that we were able to take it the next step. We have received certification by we have received approval by what's called 3C, the Continuing Committee on Certification. And the next step is going to the Board of Directors, which will be in the first quarter of 2024. But regarding patient expectations, our patients really expect that their physician, not only in urology, but all disciplines, is up to date in knowledge and skill. And the medical profession is expected to self-regulate, which I think we do well in the fact that everyone on the board and all the trustees are actively participating in urology. There was a very helpful survey that was done in 2018 by what's called NORC, and it was a diverse, large survey of the US population. And it looked specifically at questions regarding physician knowledge and ability. And just summarizing this, 98% assumed that their physician was up to date in medical knowledge. 95 agreed that the physician should be participating in some type of an educational program, and 95% expected that their physician was required to demonstrate they're up to date through qualified certification programs. This just shows where we stand with our timeline. We presented this proposal to the ABMS in November of 2020, and since then we've had 3 years to compile data on various aspects of the program, which I'll go into more detail. This is going to be the future cycle of CUC. There's 5-year cycles, and this has already brought out concern in the notification that you received in the mail and email. And I'm just going to explain it a little more in detail. We have 2 similar cycles, A and B, that are 5 years. They're not identical because of the fact that we have the complication mortality narratives and practice logs in the second tier of the cycle. You'll see how that plays an important role momentarily. But that's going to continue, and everyone is going to complete the practice logs and narratives and peer review, at least in a 10-year cycle. We recognize how much effort it takes on the diplomat's part, and it takes equally amount of effort on the trustees' part to review all that information. So while we felt it's very important, we didn't see a need to repeat that every 5 years. What we then took, everything here in black, is what you currently do in lifelong learning. But what's occurred in the past is you've had this period of time to complete it. And what we've found is that most diplomats will wait to the very last month to try to complete all activities, and then find out that it's difficult time-wise to do so. So what we've done was separated the activities out to doing one once a year. And it's really not that onerous, but it'll tell you what activity you need to complete in that year. Most important, what I'm going to spend the most amount of time on, is eliminating the 10-year exam and replacing it with short learning activities that'll be completed each year, and those are in blue. So of all the slides, this Venn diagram is probably the most important for all of us to remember. When the Board of Urology makes a summative decision on a diplomat's performance standard, this is knowledge, judgment, skill, and professionalism, we don't make it based solely on your performance, on how you've answered a question or what article you're reading. And we combine it with several different things. First is what's called primary source verification. And this just means that you have to have an active, unencumbered medical license in order to continue with certification. So provided you have that, we use the practice logs, peer review, the mortality reports, and your learning activity all together to make a summative decision. Most boards rely solely on the performance of an exam. So you could potentially lose certification if you didn't perform to their standards. Again, this is what we currently do. We've changed, or where you see the CUC learning activity, this used to be the LLL 10-year secure exam, and we've just moved that out and moved in the learning activity. So what is the learning activity? We've taken 3 learning elements that we feel best represents current educational opportunities. And again, I'm going to go into each one of these in more detail. Knowledge reinforcement is going to occur in years 2 and 4. And this is a short activity to strengthen recall on basic urologic knowledge. Knowledge exposure is occurring in years 1 and 3. And this is going to present you or the diplomat with advances in particular areas of urology or changes and advances in guidelines. And then the final 5th year is the knowledge assessment. And this is where we're going to help identify gaps in an individual's knowledge. We're continuing our learning activity in the modular content, just like it's been done in the past. We have a core component, which everyone is exposed to. So you're all exposed to the same core questions and material. And then you select one of the other 4 modules that best represents your practice. And we recognize up front that none of these modules will totally reproduce anyone's practice, but you gravitate to what you feel most comfortable in. This is a fairly busy slide. What it shows is the content in each one of those areas. You can find this online. This does change with time as we see various changes in urology occur. There might be a little more emphasis one way or another, so we can remove one content area or put something else in. But this will always be available online. You can see that core and office-based practice are very similar, and that's just basically covers general urology. And that's where a good 55%, 50 to 60% of our diplomats gravitate to. So going into more detail regarding the knowledge reinforcement, this is essentially a memory challenge. And the whole point here is by doing something on a repetitive process, you begin to remember it better. And for those of you who do any kind of word games, crossword puzzles, or number puzzles, you know the more often you do it, the more frequently you do it, the better you get at it. And the idea here is not only as you are exposed to various questions in certain areas, but this also helps your memory bring up other associated content areas. So of the 40 questions, there's 20 that come from the core data, core information, and this is basic urology, and what you can consider basic walking around urology, what you need to know in general practice if you're on call. And then there's 20 that come from your selected module. You do this in your own environment. It's on your own personal computer. There's going to be a window that's open from approximately mid-April to mid-August. And that gives you the opportunity to complete this. The reason there's such a wide span is out of respect for your schedules and vacation plans and everything. We didn't want to be too rigid. This is completely self-paced question delivery. You can choose how many questions you have at a time. From an educational perspective, if you do one a day or one every other day, you're better off as far as the memory challenge, but that decision is totally up to you. You can do them all at one time if that's what you feel. You have as much time as you want to complete the questions. The majority of them are clinical judgment and problem solving, and you have open resources, meaning that you can use whatever's available to you with the exception of talking with another urologist. We do have a threshold that you'll see. And the threshold is not a pass-fail threshold. The threshold represents the fact that you are above the minimal standard of care that the board has defined. And we put this on there because you'll see that you have an opportunity to potentially opt out of the knowledge assessment exam, year 5. If you score an average threshold of above approximately 65% in years 2 and 4. So let's say in year 2, you did very poorly, you can make up for that by doing well in year 4. From our first experience of individuals now going through 2 years, we found out that 70% have been above the threshold and have the opportunity to opt out of their knowledge assessment. This just shows what you will see when you're doing the knowledge reinforcement. You have a typical question, several responses. You select the best response, and green will tell you if it's correct, red will be incorrect, and then there'll be an explanation of why the response was correct or incorrect, and you'll also be given additional resources. What's important to know is that the scoring for your exam occurs with your first response. So you want to be careful with making that first response. You're not able to proceed to the next question until you've completed the current question. I think this is something that everybody recognizes, that the exponential growth of medical knowledge. I just put some doubling times down here, which I find interesting. In 1950, the doubling time of medical knowledge was 50 years. When I started my urology residency, it was 7 years. In 2010, the doubling time was 3.5 years. And in 2020, it was 73 days. And of all the disciplines, urology is one of the most active as far as having knowledge doubling time. And this is one of the primary reasons that we need to have some type of educational process that's continuous and not static. That gets into our knowledge exposure. And this is a partnership that's been developed with the AUA through the AUA University. And I specifically want to thank Jay Raymond and the Office of Education and all of his staff that have really worked hard developing this. We have 3 resources to use: the Journal of Urology, Urology Practice, and AUA guidelines. And the AUA has identified articles and guidelines that they feel are the most appropriate for you to be familiar with. And these get changed out on a periodic basis, removing any articles that become dated, adding new articles as they become more effective for your learning. With this, you'll read 8 articles a year. 4 will come from the core section, and that's a pretty broad area, which includes the guidelines. And then 4 can come from any of the modules. Now, in this case, you are not restricted. If you selected oncology as your testing module, you're not selected to all the articles in oncology. You can read an article anywhere in any one of the modules that you feel is beneficial to you in your practice. There's 5 questions per article. There is a CME offered, and because of that, the completion percentage for this is 80%. This shows what it'll look like when you enter the AUA University. You'll get to the page where you have the option to obtain CME credit or the activity without CME credit. Choosing CME credit does incur a fee that's fairly reasonable, $15 per article or $120 for all 8 articles if you're a member, $200 if you're not a member. And that's a fairly reasonable way to get some of the CME credit you need to get, since you have to do the activity in any case. Well, there's the illusion of competency and knowledge, and this is called the Dunning-Kruger effect, and all of us are affected by this. Basically, individually, we can't assess what our own competence is. Most of us gravitate into certain areas and become very aware of what we're doing and feel comfortable with learning with our own experiences and our patients. And as time goes on, we become increasingly confident that we know what we're doing, and we become less analytic, meaning we question less as far as what we're doing, if it's still valid. And there's very good evidence to show that as our confidence increases, our ability and our skills actually decrease, and we're totally unaware of it. And it's best stated by Stephen Hawkins, where the greatest enemy of knowledge isn't ignorance, it's the illusion of knowledge. So basically what this means is we don't know what we don't know. And autonomous, non-analytic learning leads to errors in care. This hasn't been documented in neurology, but it has been clearly documented in other areas of medicine. And there's no question that as time continues, gaps in our knowledge and judgment also become more relevant. So all of us needs assistance to identify our knowledge gaps. And that's the whole point of the knowledge assessment, the 5th year. This again is not a pass-fail exam. It's just to identify the areas, if you have a knowledge gap, where we can help direct you into those content areas and gain the knowledge that you should receive. This is 90 questions, 45 are core, 45 are modules, so it's very similar to the knowledge reinforcement you've done, it's just more questions. The difference is there is a time restriction that this activity needs to be completed in a 24-hour period. Based on our data from the Pearson testing centers where this type of exam has been given, most diplomats complete the exam in 2.5 hours. Once again, it's done in your own environment, your own resources. The only restriction is not discussing it with other urologists. And again, I can't stress enough that this is not pass-fail. It's only to identify knowledge gaps. And if we find gaps in knowledge, then you will be assigned CME activity in that specific area. And none of this is different than what we're currently doing. We've just moved it from a secure environment that's done every 10 years to an open environment every 5 years. Now, again, you have the option to potentially opt out. If you're scoring above the 60th percentile on the knowledge reinforcement, again, that's the average of 2 years, you can potentially opt out of this. You're going to see shortly that almost everybody is scoring above the 80th percentile on the knowledge exposure. So I'm going to go into just some of the results we have of 3 years of activity. For the knowledge exposure, we have 2 years, 1 completed year, and from this year, we had to end at October 1st because we don't have the final data coming in from that session. But what we've seen is that 98% of those who participated in this were able to easily complete the process. Just under 60% actually claimed CME activity. Almost everybody, 98%, were above the 80th percentile. Survey information shows that 90% felt that the articles that they read met the learning objective. 95% felt that it was presented in a very fair and unbiased fashion, and overall quality of everything was very good, 98%. We have 3 years of data going through the knowledge reinforcement survey, and this is the report of close to 1,000 diplomats. And going through each one of these as far as time spent on questions, you can see there's a fairly equal distribution between under 5 minutes, 5 to 10 minutes, and 10 to 30 minutes. Very few individuals spent more than 30 minutes on a question. This is one of the areas which I think is most interesting, and this is how many questions were answered per session. Again, from an educational point of view, it's beneficial to you to answer them once a day. Of our group, less than 2% actually answered them once a day. Over 20% answered them all at one time. When we looked at the results, those that did not, I don't want to say poorly, but those that did had the weakest performance were those that completed everything at one time. When you look at days to completion, again, a little over 20% completed this in one day. And then there was a fairly equal distribution between 1 week, 2 weeks, and 1 month. Very few individuals actually spent. They were limited to 6 weeks in time. Moving forward, you'll have 4.5 months. So that should be more than enough time to complete 40 questions. And we want, the idea is for you to do it when you have some time and you can think about it and aren't particularly stressed. Approximately 80% felt that the module that they picked and the questions they answered were relevant to their practice. 80% utilized the references for additional learning activity. Over 70% felt that the knowledge reinforcement was not disruptive to their personal or professional responsibilities. And 80% felt that it would directly help them in their practice. The last question we wrote in a reverse fashion, just to assure us that people weren't simply clicking off strongly agree and agree. And this was written that I prefer the 10-year secure exam to the present CUC protocol pilot. And fortunately, 88% felt strongly that they approved of the pilot over the 10-year exam. This is a complicated page, and I'm just showing this to show that our goal, once we receive approval from the board, is to roll everyone into the CUC at one time. You'll be rolling in at the year that you currently are in your lifelong learning cycle. And the reason for that is we're trying to eliminate any duplication in activity, so you don't perform anything twice. And if you are coming in a cycle where you've already performed the activity, you will get credit for that. And the other thing that I wanted to mention here is in response to one of the primary set of questions, and several people had this question, and it's very good and an appropriate comment. The fact that they have either just taken the 10-year secure exam, either this year or potentially last year, and they feel like they're penalized by having to roll into this cycle. And that, in fact, is not the point. And the 10-year exam was never to provide another 10 years of freedom before you're certified. It was to confirm that you had the knowledge existing at that point of time to move on to the next step. And by completing that, you will be moving into the CUC cycle. So if you just took the exam this past fall, you'll move into year one with the knowledge exposure. And if you do perform well on all of the activities and meeting above our threshold, you'll have the option to opt out of any further examinations. I'm putting this up as far as maintaining urologic certification. This has not changed from what our current philosophy is. In order to maintain your urologic certification, you have to participate and you have to perform to meet the standards. Moving forward, you will receive a certificate that is not time-based. So if your certificate comes up in, let's say, 2026, the next time you receive a certificate, it will have no date on it. So you're always going to be maintained. You'll always be certified and be maintained in continuing certification unless some other activity, either performance or participation, gets in the way. I didn't mention early on that I have this QR code here. If you do scan the QR code, you'll be taken directly to the website that provides more information. What I try to do is answer many of the questions that came in ahead of time. There are a couple more questions. We talked about the fact that this is not the same process that our certificate of adequate qualifications are going to go through. They will be doing a continuing certification program, but we need to work through those challenges again. A good question came in, a comment came in about how complicated this looks. And there are a lot of moving parts. And how are they going to maintain and stay up to date with what they need to do? And it's twofold in the sense that the board will be sending you notifications when things are due. The problem with that is emails are not always up to date. Many individuals, particularly at academic institutions, have emails that block, the servers block content, and you often don't receive the emails. The same thing is true with home addresses. So the best way to stay current is if you just systematically go into your portal. Everything in your portal will directly tell you what you have to do and what you've completed. There are a couple other questions relating to retirement, and I'm going to ask Brant if he'll can just speak to that.
Yeah, I'm glad to, David. Thanks for that presentation. It was very complete. One of the questions was plan to retire next year. What options are available for me? A lot of that is going to depend on when you retire and where you are right now. I mean, our retirement requirements are that you are in good standing with the board at the time of your retirement. You will receive an honorary certificate. It has a date and time. And effectively what that means is that it's honorary. You don't continue on with any of this, and you don't pay any fees. You could come in if you'd like to and take any of the testing you'd like, but the point of the matter is you don't have to at that point, but also you're attesting that you will no longer have interaction with any patients. If you change your mind after retired, then you've got to go back through a reentry program. That reentry program could be as different as the time interval that you're away. If you're away for a short period of time and retired for a short period of time, decide you want to go back to locums, then it may be that you have to take a module to get back in for reentry. It'd be totally up to the board, and then you'd have to get up to date on the continuing certification. So the retirement itself, if you're going to do it next year, that could be based on your timing. You could have to do nothing further but apply for retired status. Let us know when you're going to see no further patients. Let us know when that plan is to stop all of the clinical activities, and then you can get a retired certificate. Let's see. I think the question is already answered about the fellowships. If you do an unaccredited fellowship that did not lead to a subspecialty certification, then you basically would be doing the same thing that everyone else with a primary certification would be doing. There isn't a specific female urology module. The core urology does have a significant amount of female, and office urology has a significant amount of female in it. Was there anything else, David? Was there another?
I see there's a very good question regarding looking into your portal now, seeing activities
Yes.
in lifelong learning level 2. I would recommend if you want to complete anything to go ahead and complete it. You will get credit for things. We do expect when we roll this out, it'll be probably in the first part of spring. So it's going to be a few months before it's actually rolled out. And we're going to make the best effort of giving you credit. But let's say you've completed something, document whatever you've completed, taking a screenshot of however you want to do it. And when you get rolled into the CUC, if you see that there's a discrepancy, notify the board and we'll work towards providing you the appropriate credit.
Now, the question on clinically inactive, it does stay the same. You recognize that the Part B portion of the PAPs was not required, logs not required. That would be similar. So there would be pieces of the puzzle that you would not be required to do. The rest of it you would be required to do. And I think that addresses most of the questions.
I think so. All right, Stuart, I'm going to turn it back to you.
Okay, I think next we have Dr. Gonzalez is going to speak to us about the oral exam.
Thank you, Stuart. Appreciate the opportunity to talk a little bit about the certifying examination 2024 update. So as part of our mission, one of the core things we do is we do certification. And really what that is establishing and maintaining standards of certification for urologists, either initial or for those who are certified looking for lifelong learning. And really the goal of this all is deliver high quality, safe, and ethical urologic care. And we're working on behalf of the public when we do this. So what is the certification process? Well, first of all, complete an ACGME or Royal College of Physicians and Surgeons of Canada accredited residency program. And then you can sit for qualifying Part 1 examination or the written exam. Once that's completed, there are going to be some prerequisites you need to take prior to taking the oral or certifying examination. I'll get into those in a minute. But once you've completed your residency, certification must be achieved within 6 years. This is designated the period of board eligibility. So what are some of these prerequisites before you sit for the certifying exam? Well, 16 months in stable practice. Now, if you do a fellowship, you may get a 4-month credit. Unrestricted medical license in the state, where in practice and hospital privileges. Review and approval of professional responsibility action history. So any irregularities in your practice, behavior, anything like that, the board will take a look at that. And having a favorable peer and log review. And the peer review is going to be talking to your chief of anesthesia, your chief of surgery, your chief of urology, and also, as mentioned, your peers. So the practice log. So this is 6 months of all office, hospital, ambulatory visits, and hospital office procedures for each facility where you practice. The logs must be submitted electronically, and there's a certain format for the board that the board would want. So it's very important that you follow that format to the letter. If a log raises any concerns, the credentials committee may ask for a clarification, potentially an interview, defer to the candidate, or really require a site visit. And again, for recertification candidates, lifelong learning, CUC, as we just heard, there will be a similar 6-month log, which will be expected as well. So what's the purpose of the certifying exam or the oral exam? Well, we want to determine the candidate's ability to gather information relevant to a clinical problem. So you're going to be handed diagnostic tests and need to interpret those diagnostic tests. We want to determine the candidate's ability to manage the problem effectively when it's presented. How does the candidate react in timely fashion to complications or things that may not go 100% correct during a surgery? And we also want to determine the candidate's ability to act in an ethical and professional manner. And that's one of the important things that we want to get across. So what's the process? Well, a case scenario and pertinent clinical information will be handed to you at the start of each protocol. You'll get test results, images, potentially even video clips, which will be released to you at certain points during the protocols. If you get lab values, the normative values will be provided. And once you have this information, you'll then be asked to interpret these tests or images. You may need to describe surgical techniques and some in detail, manage complications and how you'd respond to a complication and what you would do. And also your interaction with patients and family members is going to be an important thing that we'll be looking for. So you got to do all this in about 50 minutes, and we'll talk a little bit about that more in a minute, but the examiners will move you along so you complete both protocols and an OSCE. So why and what is an OSCE? Well, an OSCE stands for Objective Structured Clinical Examination. It's been shown to be a very realistic and meaningful way to assess candidates. And we did this last year, and the statistics were very good on this. It worked out very well. It's only going to be about 10% of the test. So it's not going to be a whole lot more than what you're already doing, but it will be a little bit more. What we're looking for is professionalism and communication. And you may see a simulated patient, actor, that you may need to converse with, and interpretation of diagnostic studies, and maybe even video clips. So the board feels pretty strong there's no need to alter your study preparation for an OSCE. This is stuff that you've already learned in residency and also with your study preparation. And as we look to expand OSCEs, future considerations may include technical assessments. So the certifying examination process, the summary. So you'll have 2 sessions and a half days separated by a very short break. Each 50-minute session will have one protocol of 10 items, another protocol of 10 items, and then an OSCE of 5 items. There will only be one examiner delivering a protocol or an OSCE. There'll be 2 examiners in the room, but only one will be delivering one at any certain time. They will not switch back and forth within a protocol, too confusing. So an examiner will change for the second session of 2 protocols. So you get 2 new examiners after your break, and then both examiners will score. So it's important to know the examiners are blinded to your training, Part 1 score, peer review, practice pattern, and location of the candidate. Examiners are queried prior to the exam to ensure they do not know the examinee. Examinees will be asked prior to the exam if they have a close relationship with the examiner, be it either through a training program, visiting professorship, or research. So it's important that the examinees do alert the board that they do have a relationship with the examiner. The exams are recorded, and the reason we do this, in case there's any discrepancies in scoring between examiners, the recordings are destroyed once the results are released. The results are released about 4 weeks from the date of the exam. So scoring. So scoring is in the candidate's favor. It's through criterion reference testing, and this is used to determine the minimum pass level, which demonstrates the competency necessary to practice. So it's done on a point system for each section within each protocol, in addition to an overall assessment, which you'll get. So failing to answer one section correctly does not affect the next. So it's very important for the candidate to understand that if you get something wrong or you feel you want to go back, not to do that, but to keep moving forward, because those points are just as valuable as the points behind you. Scoring is very objective and highly reliable. So the difficulty of the examiner is not a concern, since the answers are fixed, objective, and clearly identified in the scoring rubric. And really, question and protocol difficulty, in addition to difficulty of the examiner, are going to be adjusted. So that's going to work in the favor of the candidate as well. So this really just ensures the scores are not biased by any different facet of the exam. This will all be taking place at the Ames Center, which is about 10 minutes from downtown Raleigh, North Carolina. This will be our third year there. 32,000 square foot center. It's also the home of the American Board of Anesthesia. Very state of the art with technology, and very comfortable in that particular building. So candidates will stay in a hotel about 5 minutes away, and they'll be bused to and fro. Just an example of an exam room in the Ames Center. So you can see where the two examiners will sit, or the examinee will sit, and then you can see where the computer screen is going to be for images. So why not have a virtual exam again in 2024? Well, the board weighed the pros and cons and felt in-person exam was more reliable and fair. All the other boards noted lower scores in the virtual exam, and we happened to avoid glitches when we did this about 3 years ago, but several boards admitted that they did not avoid glitches, and there's some major problems. So one of the reasons why I want to stay away from it, but we also want to bring this to the candidates, and the majority of candidates prefer an in-person exam on the survey that we sent them. It's also interesting to know that 100% of those who did not pass felt the virtual exam put them at a disadvantage. So the ABU has formed a standing DEI committee. Cheryl Lee is the current chair. And one of the things that this DEI committee did was took a look to make sure that all oral board examiners took part in an online implicit bias module. And this was designed to raise awareness of what implicit bias was and try and eliminate it. So the committee has begun the process of examining results of past exams to assess for any kind of variances. And, the good news is that from gender perspective, no differences have been noted in the certified exam results. And we will also take a look at race and ethnicity going forward. The COVID policy in 2024, all participants will attest to being COVID-19 symptom-free at registration the night before exam. All participants must acknowledge that the ABU cannot guarantee that you will not be exposed to or contract a communicable disease at the exam, and masks are going to be optional. And I thank you for your time. Take a look if you have any questions.
Chris, there was a question that came through on the chat about the difficulty with some EMRs providing the reports and interfacing, specifically the one at the VA. So insofar as not being able to the VA system cannot interface with the log, what we're asking for as far as the data? Yeah, the question says practice log requires an EMR system interface. This does not seem to be available through VA systems. How can we deal with that? I know we've have several candidates we just looked at who had VA logs, so there must be some way. Yeah, we'll need to get back to you on that, as far as how that's going to work. I mean, I don't know if Charlie, if you're still on. Yeah, and whoever's reaching out with that question, thank you very much. We want to make this easy for you. Just email the board directly, and we'll figure out the solution for you.
Yeah, let me say one thing about that. We have plenty of people that are in the VA system. There are VAs that have they're more recalcitrant to do it, and they're very slow in getting them, but they do have electronic medical records. We do have people that are out in practices that do not have electronic medical records. We have Canadian colleagues. We have foreign trained colleagues that are coming through our board system, and they do them by hand. You can record your cases by hand. It's an awful lot for the board and for you. But that is something for the VA cases, which generally a small portion of everyone's log that people sometimes have to do. But I will tell you, this year alone, we had several folks, initial certification, that came out of the VA systems and were able to get their EMRs. Now, each case can be individualized. So if you're having problems at your particular VA, welcome to talk to you about it. But it's not that we don't have plenty of VA folks in the pool, both for initial certification and recertification.
Great. I think that's the last one there. Okay, great. Thank you very much. Dr. Gormley.
Thank you very much, Stuart. Welcome, everybody. I'm going to be giving the update on the ERPs today, or urogynecology and reconstructive pelvic surgery. So in the next 15 minutes, I'm going to give some information about subspecialty certificates. I'll discuss why the name change from FPRMS. I'll then discuss the current state of ERPs within urology. We'll talk about the current state of training in ERPs, both accredited fellowships and non-accredited fellowships. And I'll then talk about our relationship with ABOG as it relates to the ERPs fellowships. So in terms of subspecialty certificates, urology has two: pediatric urology and FPRMS or ERPs. Subspecialty certificates means that the program or the fellowship is ACGME accredited and therefore ABU certified. Within urology, there are a number of other fellowships that are accredited by subspecialty organizations, things like the oncology fellowships that SUO certifies, or endourology fellowships that the Endourology Society accredits. But these are not ABU certified. There are also completely unaccredited fellowships in a number of specialties, including FPRMS or ERPs. So in terms of subspecialty certification, once a diplomat becomes subspecialty certified, they still have both their subspecialty certification as well as general urology certification. One of the differences between FPRMS and PEDS is that the qualifying exam for FPRMS is administered with ABOG. For recertification or lifelong learning, one is recertified within the subspecialty only, but they maintain both certificates. And the reason that that happens is part of the recertification exam is 45 core questions. And then whether it's PEDS or FPRMS, there's 80 additional questions. So let's talk now about the name change from FPRMS to ERPs. ABOG and ABU announced this name change of the jointly sponsored subspecialty of female pelvic medicine and reconstructive surgery to urogynecology and reconstructive pelvic surgery in October of this year. And it will become effective January 1st, 2024. The name change was initially proposed by ABOG as a name that they felt more accurately reflected the subspecialty and gave increased recognition amongst the public, patients, and referring healthcare providers. So we supported this name change. And before we did that, we had input from both SUFU and the AUA. The ultimate approval for the name change came from ABMS, or American Board of Medical Specialties, in June of 2023, and this followed a period of public comment. It was reviewed by COCERT, which is the Committee on Certification, and then finally approved by the ABMS Board of Directors. And I'm told there was not a lot of comment from urologists during that period of public comment. The ACGME has not yet changed the name of the fellowships, but plans to, and that is open for, or was open for public comment, and that name change is expected to go through to ERPs, and that should take place in July of 2024. The most important thing to remember about this, though, is that the ultimate goal of the name change is to make it easier for patients to find the care that they need. And the feeling is that patients identify more with urogynecology, whether it's a gynecologist or a urologist who's providing the care, than they do with FPRMS. So let's just go back a little and talk about the history of FPRMS and now ERPs. The FPRMS certification was approved by ABMS back in 2011. ABOG and ABU co-certify FPRMS fellowships. There wasn't initially, but there is now an effective memorandum of understanding between the two boards, and we think we work really very well together. ABOG, though, is the administrative board. The first subspecialists, including those who were grandfathered, were certified back in 2013. To date, there are approximately 1,700 FPRMS subspecialists in gynecology and urology. 335 of those are urologists. So that gives us about 20% of the subspecialty. So if we look at the current initial certificates that have been issued by ABU, there are 335. 139 of those were grandfathered, and grandfathering only occurred for 3 years between 2013 and 2015. Recertification in the subspecialty is now occurring, and 221 people have been recertified. There have been 5 people who have reverted to their general certificates rather than recertify in the subspecialty. So for numbers for initial certification, these are the numbers who have sat the exam. So it ranges from 8 in 1 year to a high of 17. And one thing to remember is it takes time for one to get their initial certification. Chris pointed out what the initial certification process is for the general certificate. And remember, people have to do that first. So they finish a fellowship, then they get their initial certification in their general certificate, and then they do the initial certification for FPRMS. So it can take a number of years to get there. So numbers for recertification. Recertification just started in 2020, and to date, anywhere between 41 and 70 people have recertified each year. So let's move on now and talk about training. The best data for who and how many programs there are comes from the ACGME. So there are currently 74 programs in FPRMS or ERPS. 16 of these are in urology and 58 are in gynecology. And again, this puts us at about 20%. The good news is, though, urology is actually growing. So urology has increased the number of programs by 23% over the last 5 years, and that compares to 8% in gynecology. And we've seen an increase of 12% in the number of fellows, and that was 6% in gynecology. So we're growing at a faster rate than gynecology is in terms of our training programs. There are some differences between the curriculum requirements in FPRMS for urology versus gynecology. Urologists do 24 months of training. 18 months must be clinical, and 6 can be research or an elective experience. That's different than the 36 months that our gynecologic colleagues have to do. They do 24 months of clinical activity and 12 months of research. Initially, when this was set up, it also took into account that OB-GYN residencies are shorter than urology residencies. The scholarly activity has some differences. The OB-GYN graduates must complete a thesis, and urology graduates must complete a scholarly manuscript or QI project paper. I would say, as a faculty member who's involved in a gynae fellowship that is thought to be a good gynae fellowship, I've sat on our thesis committee now for 3 or 4 years, and I would say the thesis, aside from the fact that the candidate has to defend it, it ends up being very similar to a scholarly manuscript, and it's often published in a peer-reviewed journal, but it's not much different than a manuscript that a urology fellow may write. So in terms of non-accredited fellowships, I put this slide up. This is from what shows up on the SUFU website about training programs. And there are currently 14 non-accredited fellowships in urology for FPRMS or ERPS. Most of these only take urologists, but some of them will occasionally take a gynecologist. They advertise themselves as being either or. Next, please. So in terms of length of fellowship, it's often been thought that non-accredited fellowships exist because people want one-year fellowships, and that certainly is the majority of cases. 12 of the non-accredited fellowships are 1 year, but there is one that is 2 years, and interestingly enough, there's one that is 3 years. Some are also flexible and will do either 1 or 2 years. So in terms of some of the differences between ABOG and ABU, with the fellowship, ABOG is the group that sets and administers the qualifying exam for the subspecialty, and they do that for both gynecology and urology trained fellows. They own and have a copyright on the question bank. The ABU, we feel that we have a close working relationship with ABOG, but there's a couple of things to keep in mind if we were to try to end co-certification. It would be difficult because they control the question bank, and because they have a copyright on it, it would be difficult for us to start a new question bank without getting into copyright infringement. We also need to remember the differences in numbers in terms of gynecology trained specialists versus urology trained specialists. We are the much smaller group. At various times, other alternatives, such as us becoming a qualifying board or changing from a sub-certification to a focused practice designation, have been sort of discussed. There are problems with both of those, and currently it's not recommended. There are a number of us from ABU recently met with the AUA, GERS, and other stakeholders to discuss the future of reconstructive urology for both men and women. And the consensus was that the co-certification is really going very well, and we should continue to support that. For recertification, it's the ABU who continues to set and administer the continuous certification exam in ERPS. We will be rebenching this exam in January of 2024, and we're currently working to improve the bank of questions to better represent the subspecialty. So ABOG and ABU currently have what we feel is a very good working relationship. Brant Thrasher, our executive director, worked very well with George Wendell. ABOG has a new executive director, Amy Young, and there's no reason to believe that that good working relationship won't continue. ABOG recently has sent us invitations to send representation to a number of meetings. This included the ERPS division meeting in August, the job task analysis for ERPS in October. That's where the basically an assessment is made of what knowledge and skills does a newly certified ERPS practitioner need. And then they've also invited us to the interim ERPS division meeting in January of 2024. At ABU, we've responded to these invitations, and we've sent representatives from the subspecialty whenever we've been asked. As one of the people who went to ABOG for the job task analysis, I would say that they welcomed us to their meetings, and they were very accepting of our input. So all in all, I think we have a good working relationship, and I'm confident that this will continue. Thank you very much for that, and I will take questions at the appropriate time.
Just looking through the chat to see if there's any questions that have come up yet. The live stream is a little bit delayed from while we're doing this Zoom. We have an alternate universe going on. So
actually, sorry, Stuart, can I just make one comment?
Please.
One thing I forgot to mention, there is a section under the ERPS portion of the ABU website where there is a document called Frequently Asked Questions about ERPS fellowship, in terms of particularly focusing on the name change. So you can get information there about what it will do for certificates moving forward. Thank you.
Okay, good. That actually answers one of the questions in the chat. Am I able to change my certificate from FPMRS to URPS? How can I do that? I assume you go to that FAQ sheet and that'll tell you?
Yes. Yeah.
Great. Thanks.
Well, we have just to answer that question. We are not going to reissue certificates for people that have already certified. We'll do that going forward. We're not going to reissue for everyone that has certified in the past.
All right, great. And then we'll address other questions as they come up at the end. So very briefly here at the end, want to speak to you about some research grant opportunities available from ABMS, which is the American Board of Medical Specialties. That's the big overarching board that all the specialty boards roll up to. The first one, this is the third year of this program, called the ABMS Visiting Scholars Program. We had two urologists get funded grants in the first cycle, the first year. We didn't have any applications the second year. We're hoping to get some applications this third year. Next slide, Lindsay. Great, thank you. So to apply for the grant, you are to focus on one of these program priorities. I won't list them all. They'll be available for you to review later. The first four are general priorities for all ABMS specialties. And the last group are the urology specific priorities that the American Board of Urology trustees have identified as important for our specialty. Next slide. These are fairly small grants. They are primarily intended for new investigators as a pilot to get some work going, answer a brief question. Awards are up to $12,500 to support direct costs and travel. Applications aren't due until next June. So we've got time on this one. Watch for more announcements from the American Board of Urology, from the American Board of Medical Specialties. And then there's also a link here that you can use to get some more information directly from the ABMS website. You can also search for this Visiting Scholar Program on the ABMS website. Next slide. So now we have two new grants. This will be the first year for these from the ABMS Research and Education Foundation. There are two flavors. The first one is, Great, thank you. The first one is under the very general rubric, general certification. So almost anything that applies to certification can be applied to this. These are investigator-initiated proposals. Really anything that fits under certification under the ABMS mission is fair game. And these are much larger grants in the area of 50 to 75,000 for 1, 2, or possibly even 3 years, depending upon the work you're doing. And then the second one is called Diagnostic Excellence through Certification. This is much more specific and a little bit different organization. These are proposals that actually come together from the member board and a collaborating independent investigator. So for something like this, the independent investigator, if they have an idea for it, they would approach us, the trustees, let the ABU know, and we would work out a combined application. The focus here is the specific area of improving the core medical activity of diagnosis. These are much larger grants now for 100,000. Now, the letter of intent for the submission is due on January 30th. So it's just a couple months, less than 2 months. And again, there's another web link here on the ABMS website, or you can just search Research and Education Foundation, and you will find this. There's a nice PDF that explains all the details of this that we're not going into in detail now. Just want to let you all know about these. And I think now we're open for any other additional questions that come up.
While we're waiting on those, Stuart, let me make a comment. I'm pleased to announce that the ABMS has raised the visiting scholarship funding to $15,000. That will go into effect this cycle. And of those $100,000 grants you just heard about in diagnostic, there are going to be 3 offered this year. So I think it's hopefully we could get some good ideas and get some more folks that are invested in this. But we think it's a unique opportunity. We know we've got a lot of bright people in urology that could apply for these programs.
All right, great. So we've got 2 new questions in the chat. The first one, I think Dr. Joseph addressed to some extent with his comments already. There's a general question about communication with diplomats and candidates regarding next steps in their process.
We will be sending out, this relates to the CUC, I don't see the question, but the board will be notifying everybody if we get approval from ABMS Board of Directors to move forward. And at that time, you will receive information about where you stand, how things are going to be moving forward. I see there's another question regarding the CUC process for ERPS candidates. At the present time, the the presentation given is for the primary certificate and not our certificates of added qualifications. There will be a continuous program for both certificates of added qualifications. But again, we have to work through some unique hurdles and challenges with each one of them.
Right. I think, Dr. Joseph, you made the really important comment that folks should really go to the Diplomat portal to try to figure out what's going on. I mean, if you look at the general table that you showed of where you're going to figure out, depending on what year you're doing, you'd get very confused. Simple answer, go to your portal. It'll tell you what to do. Yeah.
And updates on the CUC will not be available there until we get approval to move forward. So when you go there now, you'll see where you stand in your lifelong learning cycle.
And remind us again, when is that final approval are we looking at for that?
Brent would know. It's going to be in the first quarter of 2024. It's at the board meeting.
Board meeting's in February, so by the end of February, we'll have full approval by the board, or we expect. We'll know then.
And then we'll try to move it forward as quickly as we can.
All right. Well, unless, are there any other comments that any of the trustees would like to make before we close?
There's a question about what's the recertification process for ERPs. So the
good.
recertification process is very similar to the prior lifelong learning. You're expected to do the PAP. Again, you can see this on your portal. And then at 10 years, you will do an exam that will have both some general questions on it and then questions specific to ERPs. And then you have to, before the exam, you have to put in a log, peer review, the sort of usual things that one does as part of recertification.
Stuart, I saw a question earlier too about they were asking the person asked if we were looking at skills assessment for the certifying exam. The answer is yes. We're looking at all different types of technology that's out there and what people are doing. So not really anything formative yet, but in very early phases.
I think it'd be important, Chris, to let folks know that it's similar to what we did with the structured clinical examination edition, is that we looked at this very thoroughly for a while. We tested it, we piloted it. All of this is not going to be a surprise to anyone. We'll make sure that the announcements would come through the SAU, multiple portals, whether that be email, it could be Instagram, anywhere else that you might find on social media. We're going to try to put out mailings and any other communication portals that we can, but it's not going to happen overnight. And these are the kind of things that we're looking at. We need to change with our learners. There's no question that I think every surgical board now at ABMS, all 10 of them, are looking at ways to incorporate some sort of clinical assessment. We don't want the certifying exam, never have wanted the certifying exam to be a simple extension of the knowledge assessment. We need to be looking at something very different, which is whether the people that we're testing are actually safe to do these procedures. And that's really our charge, to make sure you're safe to practice and you're practicing within a standard of care for the American public. So as we're looking at this, we're doing it very thoughtfully. We spent an awful lot of time researching the different technologies, but it's not something you're going to hear about suddenly next year. We're going to add in some clinical assessment you weren't ready for. So don't be worried about that at all.
All right, great. Well, it looks like it's been a few minutes since we've had a question trickle in. So we seem to have caught up with our Zoom live stream delay. So I think we're okay to finish up. All right. Thank you all very much for joining our town hall this afternoon. Have a great day.
Thanks, everybody.